cancer is it's almost become like a tsunami. This next decade is going to be a decade of cancer for India. It was totally the reverse of all the other patients. His request was, doctor, don't tell my parents that I've got cancer. Everything is adulterated. Let it be the drinking water, let it be the vegetables, the meat, let it be the fish, and let it be the air. Let it be whatever we consume or whatever we breathe, whatever we drink is adulterated. Open whipples procedure to robotic whipples procedure, and almost I can say it's become the gold standard of for any patient undergoing a whipples procedure. Robotic has become the gold standard. See, that's something very unique to Apollo, where we get purely complex cases. It's not like we always, sometimes I as a surgeon will think, when will I get an easy case to operate? It'll be like totally complex case. 7-8 years ago, insurance will never approve any robotic. Now they are approving. Government of India has made it mandated that every insurance company should approve one of the robotic procedures based on the policies and things like that.
Greetings of the day, the New Indian Express audience. Today we are joined by Dr. Venkat, Senior Consultant, a Surgical Oncology at Apollo Cancer Center, Chennai. He has immense experience with the complex surgeries and a patient-oriented care, which had forefronted Dr. Venkat in the advanced surgical oncology. And we are honored to have him with us. Welcome, Doctor.
Thank you, Sundar.
Dr. Venkat, what inspired you to choose the specialization in surgical oncology, and has the field evolved ever since you started the practice?
I started when I was doing my post-graduation in general surgery. That's the time when I started I always wanted to do something different, and I was very interested in oncology. Say, in general surgery, there are a lot of specialties, but somehow from those days I was inspired towards oncology.
Mm-hmm.
I always wanted to do something which is a little different from others.
Mm-hmm.
See, when I started this, I'm talking about somewhere around 98, 97, 99, those times. And then 2000, when I had finished general surgery, so that's the time I thought I'll just take up oncology. The main thing was, it's a different kind of a story. When I used to travel from here to my college, every day I used to make a stop on the traffic signal near opposite Cardiac Cancer Institute. It was a default stop.
Yeah.
See, every day I used to see the patients walking up and down. I used to find that a little challenging for them. Those days when I was wanting to take it up, no one, even my professors and my head of department, all of them, they just really did not want me to continue in this specialty. They said the outcomes are bad, please don't take up this specialty. So those days when I started, all over India, there were only 8 seats, we call it as seats, all over India in surgical oncology. So then somehow I put my foot down. I said I just wanted to do this. And then that's how it started. Basically my interest, and by default, I used to stop in Cardiac Cancer Institute signal on the way to college every day. So that, I think these two put together, combined, it just so happened that I wanted to take up surgical oncology.
Can you share a memorable case or a breakthrough moment which redefined your passion towards this cancer care?
See, there are different point of time in the career. There will be different patients and different things which you'll be seeing. See, one thing initially the cases, whenever the issue is even among doctors, let it be physicians or surgeons or anything like that. Generally, whenever the patient comes with cancer, generally what I've realized is, even in their mind, let it be the treating physician or a treating general surgeon or someone, they give it up upfront. They don't even, it's like their mind. I know the mind because I've been in that journey. I know the mind. They always think that, okay, it's not going to work out. It's maybe a stopgap treatment. That's what we are giving. End of it, the outcomes are not going to be good. That is the mindset in which the treatments they start. And again, there are many patients, many cases and things, but now treatment has evolved completely different. I'm talking 25 years is a very, very long time in oncology, because I will say almost every 5 years, the treatment and the protocols drastically change on an average. Say what treatment, when I was doing a postgraduate, whatever treatment which we used, I'm talking about post-graduation in surgical oncology, super specialty, what I did, the treatment what we used to offer then is totally obsolete now. The treatment does not hold good at all. So absolutely it's obsolete in all cancers. So in the last 25 years, it has changed drastically. If as a surgeon or a oncologist, you don't keep yourself updating or upgrading yourself, definitely whatever treatment you're doing is totally obsolete. So, and see, I started realizing in the West, they take it more seriously. In the West, the treatment of cancer was taken more seriously and their approach was more curative. But here it was more of, say, okay, let us try. It's up to a patient's luck if it works and things. So that was, I'm talking about when I was a post-graduation in general surgery. Then when I entered into oncology, the things changed and then my outlook changed and then the treatments keeps changing. And every 5 years, if you see in the medicine, I can say the maximum research, the maximum trials, the maximum changes which has happened is only in oncology. Now, let it be in the medical side, the surgical side or the radiation side, it's only oncology. So I think memorable cases as such, at every point of time in your career, you will see different types of cases which stand out. There'll be a patient, say, there is something called advanced pancreatic cancer. Advanced pancreatic cancer, genuinely he presented with a bad jaundice and he was in a bad shape, biopsy proven, scans proven. I genuinely thought he is not going to make it because scans show that there's involvement of major vessels. Jaundice is there, you cannot give a chemotherapy, and chemotherapy response in this kind of pancreatic cancer is not so great. But I was surprised to see something. After 4-5 months, he again walked into my OPD, the jaundice had gone. So even today, I don't have an answer to it. Maybe I can just put it as a condition called spontaneous tumor regression. I don't have an answer. Again, there are different set of patients where they fight it out. It's not a question of fighting means fighting. It's just a subtle mental that strength what they carry with them. They don't take it seriously. They don't take it to their heart. They just go with the flow. They go through the entire treatment with a smile. And there have been young children which I've seen. There's a young boy who had done a major surgery some 20 years ago. His only request was, he was like 19, I remember very well. He came from somewhere from Assam. His parents those days were not very educated. This was a very educated college, just first year, second year college boy. We had to do a major surgery. His request was only one thing. It was totally the reverse of all the other patients. His request was, doctor, don't tell my parents that I've got cancer. You just tell me everything, I'll go through it. Till date, he is doing well. And there have been many times where we have learned a lot from the patient. That is how to approach the entire thing. So I think what sometimes we share our knowledge, sometimes you need to keep observing the patients, how they do things, and that you can take it in your practice and go forward. At every point of time, there have been different patients, innumerable patients, and all have been like different examples. All patients stand out alone, the way they struggle, they handle it, they come out stronger. It's a lesson for us also to go through this and things like that.
That's amazing, doctor. Like, how did this Apollo Hospital shape you in professional evolution, particularly in this complex surgeries and that?
See, as such, something different about Apollo Hospital is very unique. See, Apollo is one of the first corporate hospitals, and it's a pure tertiary care center. Now everyone calls them a tertiary care center, but it was one of the first pure tertiary care centers. See, we used to get a lot of patients, let it be from Northeast, Assam, Kolkata, those sides. We used to get a lot of patients from abroad, Oman and those kind of patients. See, the unique part of Apollo is that we used to get only complex cases. Because all the easy cases, the patients will get operated locally. See, that's something very unique to Apollo, where we get purely complex cases. It's not like, we always, sometimes I as a surgeon will think, when will I get an easy case to operate? It'll be like totally complex case. That's something very, very unique to Apollo, because we have got the system in place. It's not only the, as a surgeon, medical side, radiation, let it be if you require a cardiologist support, you require a vascular surgeon support. It's pure, and the trust in which, and the system is in place. That's why we get a lot of complex patients in every specialties. And as you start doing complex surgeries, you also evolve, and your skill sets improve more and more. Your outcomes becomes better and better, because from day one of joining Apollo, the surgeries what I have done is only a challenging cases. So see, when you're going to work in some place, you need to get this patient, those set of patients to challenging cases to develop your skill sets. That's where Apollo has really played in the system, the environment in such a way that it's very, very forthcoming to do something new, innovative, and everything should align and fall in place. That's the way that our hospital keeps working, and we keep say there's something at Apollo is like some hospitals, they set up the system and the system doesn't change. Here the system, again, as I said, it keeps changing. See, it's very rapidly changing, that you need to keep updating, you need to keep moving forward. Every 1 year, 2 years, it keeps evolving itself. That's something very unique to Apollo, which I have not found in any other hospital.
Could you tell us this, how many number of gastrointestinal cancer cases in India, and why is it increasing?
See, first of all, coming to cancers itself is increasing. Earlier days, you would have seen, like, say, when I started my career, maybe 25 years ago, or we are talking about 30 years ago, 40 years ago, someone having a cancer is like, in one locality is a big news. Someone having a cancer in one particular locality, in maybe if you say one colony or something like that, among our entire relative circle, one person having a cancer is a very, very big news. So now it's not like that. See, imagine, I feel so bad to say that cancer is, it's almost become like a tsunami. This next decade is going to be a decade of cancer for India. See, now almost it's very sad. Almost every family, at least one member has been affected by cancer. It's going in that direction, where almost every member, it's become very common that almost every member, at least one member of the family is getting affected with cancer. See, in cancer, there are various causes. To me, most of it is idiopathic, where we say the reasons are not known. But there are a few cancers where you got a solid reasons. But I will squarely blame it on the environment and stress. So because our lifestyle has completely changed. All of us are in the city, everything is adulterated. Let it be the drinking water, let it be the vegetables, let it be the meat, let it be the fish, whatever let it be the air, let it be whatever we consume or whatever we breathe, whatever we drink is adulterated. So this is not like earlier. Say, imagine even now people living in villages, they're blessed to have a good air, blessed to have good food and things. So that's why now again, we're going towards organic and things like that. I think I will definitely say the stress what people go through. Again, earlier it was simple. All of them used to work for a 9-to-5 job in the government job and go. There's nothing called, the targets or anything like that. I think that's one mentally, that again, the targets, those things, environment, everything put together definitely increases the chance of not only malignancy, most of the diseases also. And this is the way why it's increased and things like that.
So following that, we can identify who are vulnerable to this GI cancer cases.
So yeah. GI is a very vast specialty. It starts from food pipe, esophagus, stomach, pancreas, colon, liver. Everything comes under GI. In Chennai as such, one of the commonest GI cancers is the stomach cancer. One of the commonest cancers is stomach cancer in the Chennai Cancer Registry. And then colorectal cancers are very, very common in Chennai. And then comes again pancreas. Pancreas is never a very, very common cancer anywhere in the world. But it's one of the cancers. So stomach, colorectal, esophagus, these are all very, very common GI cancers which we come across and things like that. It's again, whatever I've told you, the environmental factors. Along with the GI cancers, something unique has also got diet. Excessive eating of barbecued meat and those kind of food and food which are very high in fat, sedentary lifestyles, all these also causes GI, stomach and colonic cancers as such.
Could you tell us about this gastrointestinal cancer, invasion in pancreas, and how complex it is in surgery actually?
So, okay, this is in particular to the pancreatic surgery.
surgery.
So, pancreatic surgery, okay, before the surgical part, I will say pancreas is, say, if you divide the abdomen into a ground floor and the basement, the pancreas becomes, it's exactly in the basement. And it's called retroperitoneum. And just for simple understanding, I'm calling basement. It's in the retroperitoneum. It's exactly in the center of the body, human body. Exactly, almost center of the human body is the pancreas. Another something different to it is just above the pancreas, you've got the stomach, you've got the large intestine and small intestine, and then all those. One side, superior aspect, the liver is there. And just beneath the pancreas, you've got all major blood vessels. There's something called superior mesenteric artery, superior mesenteric vein, portal vein. So it's in a very complex location. Anatomically, it's very, very complexly located. And it's exactly deep-seated in the body, in the center of the body, surrounded on 360 degrees by important structures. So that's what doing the investigation, say for instance, if you're going to do a biopsy, it becomes challenging because of the location. Again, if you're going to do a surgery, because it's surrounded by vital structures and it's in the depth, that makes it more challenging for a treatment of pancreatic cancers.
The launch of this robotic pancreatic surgery program, the Whipple procedure, it's a historic milestone for this hospital. How does this mean to you, like personally and professionally?
See, it just didn't happen overnight. It just didn't happen overnight. See, for you to be no one can just start doing a complex robotic procedure upfront. You need to be very, very, very extremely good in doing a open whipples pancreatic surgery. See, this I've got a maximum number of whipples procedures in our organization, and have been doing it for the last 20 odd years. And we have done different, as I told you, in Apollo we get a lot of complex procedures. As I told you, like this surgery, it takes time to do. You need to keep doing it on a regular basis so that your skills improve, your outcomes improve, and you need to be very patient. You cannot approach this surgery like some other, for instance, a colorectal surgery, because the precision required even for open surgery for whipples is something different. The preoperative preparation is different. Everything is different. So, first of all, this entire thing, it's one of the byproduct is only this one. But again, this is a long-standing. You need to first be an extremely good surgeon who can consistently give good outcomes. Touch wood, by God's grace, we have done innumerable whipples procedures. We have got extremely good outcomes and things. That's when, again, a newer technology we wanted to combine the newer technology and proceed with the whipples. So again, this program of robotic whipples procedure. So whipples procedure can be done for a pancreatic cancer. It can be performed for a duodenal cancer. It can be performed for what is called a periampullary. That is the common bile duct. There's a tumor which occurs at the end. Those common bile duct tumors, distal common bile duct tumor cancers. So this whipples, starting the robotic whipples program, is a long journey, but again, we wanted to integrate it and we have got good outcomes of it. Again, there are a lot of advantages which we have seen. It's more meticulous surgery. Open surgery also takes time. Whipples definitely takes another 3-4 hours extra and things. Time is not an issue, but end of it, the outcomes is more important. From the time of admission to time of discharge, more than discharge, the time of patient coming back to normalcy is most important. So for this program is extremely important, and it's very, very close to us, to our heart. And all over the world, doctors have moved on from open whipples procedure to robotic whipples procedure. And almost I can say it's become the gold standard of for any patient undergoing a whipples procedure. Robotic has become the gold standard.
Following that, like the diagnosis, surgery and chemo, only the surgery part has been changed. Other than that, the diagnosis and chemo has been the same.
Surgery. Okay, I'll put it this way. As I said, the pancreas in the center of the abdomen. Diagnosis as such, getting a biopsy is a little challenging. If you ask me, the last 20 years, what has changed? 25 years. The only thing which has changed is there's something called endoscopic ultrasound We do what is called an endoscopic ultrasound and a biopsy. That has come for last 10 years or so, because in the last 25 years, that's the only thing which has changed. And maybe a PET scan, the PET scan which has changed. These are the two things which has changed the last 25 years or so, which was not there in maybe early 2000 or something like that. Another thing is coming to chemo part. See, pancreatic cancer as such is a predominantly a surgical disease. The response to chemo is not great compared to, say, if you're dealing with stomach cancer or colonic cancer or ovarian cancer, the response to chemotherapy is better. But compared to that, pancreatic cancer, response to chemos are not so great. And next thing is the chemo as such, the basic medicines that has been standard for the last 15-20 years has been same. Newer immunotherapies have come. And this is the thing about and surgery, lot of changes, the same procedure which we are doing it robotically.
Okay.
Another thing is earlier whenever the tumor is involving the blood vessels, say for instance, the tumor involving the portal vein, we will call it as inoperable and not proceed. Nowadays, we give chemo and reduce the burden of the disease. Then we go ahead and do a surgery with a vascular reconstruction. So this is called extended whipples procedure. This is also changed because all this has changed because of the advancement of let it be the anesthesia part, post-operative management part, vascular part, and all this have changed. And all this have also improved because of understanding of the disease. So definitely, say, medicine will keep evolving, things will keep changing. Definitely, this is not the end of it. Again, another 10 years from now, we'll be discussing something totally different. There might come a time where, touch wood, they might even say pancreatic cancers can be cured just by medical or radiation aspect. That might also come. We need to be open for it.
So how does this program stand apart from the traditional open or a laparoscopic methods?
See, compared to compared to open surgeries are definitely morbid surgeries or obese person, we need to make a big incision, we need to use huge retractors to retract, and that causes more blood loss, post-operative pain. Whenever we use this huge incision, patient will have little bit difficulty in breathing. So they develop what is called atelectasis, the lung infections, fluid around the lungs. And then this huge obese patient, they cause infection of the wound. And again, all these are challenges. When you compare to laparoscopy, again, laparoscopy is, the finesse and here in robotic, everything is under your control. You are the surgeon, you are the assistant who is handling which organ should stay where, and you also deal with the camera. So almost it's robotic, you do 3-in-1. You do every job. Say your assistant is only a robot and everything is under your control. This makes it more fine. And again, we do what is called a intracorporeal anastomosis. Whenever you do Whipple surgery, after removing the tumor, we join the pancreas with the small intestine and the bile duct and stomach and all that. All that we join it in the robotic system. For intracorporeal suturing, this is extremely good. And we get a 20 times magnification. That makes it the clarity, the blood loss is less, the pain is less, the clarity is very good, and the post-operative major, these complications, like wound infection, atelectasis, all this is not there. All this are the biggest advantages of robotic.
With the patient, how are they layered? Are they confident enough to go with this approach? Are they hesitant? Like, are they asking any questions?
No, I understand. There are different types of patients. I have had a patient where when we give them the best treatment, not only this robotic, some other procedures, they'll say, I don't want a robot. Because they are prefixed in the mind, they think differently, they think the robot as such might go technically, some challenges might be there, it might conk off, it might do some steps which the doctor might not do. It's not the case. Again, we explain to them, again, it's not the case, it's every millimeter of movement inside happens only with the doctor who's operating and things like that. And again, there are different, some patients, this is one thing. Most of the patients will say, okay, doctor, whichever you feel is the best, whichever is scientifically approved, we go with it and things like that. Almost they'll be, if we are revisiting this conversation about 10 years from now, you will see that the most of the surgeries are going to be robotic. There's no looking back into it. Let it be gynec side, or let it be the urology side, let it be gastro side. Everything is going to be robotic. It's definitely here to stay, and definitely there'll be another 10 years later. There'll be a newer technology which we need to get used to it and things like that. I think robotic has got a lot of advantages, and patients' acceptance are high. One of the challenges, which there'll be a challenge with the insurance. So many challenges are there, and again, those all can be mitigated, and we can keep going. And now, say I'm talking about 7-8 years ago, insurance will never approve any robotic. Now they are approving. Government as India has made it mandatory that every insurance company should approve one of the robotic procedures based on the policies and things like that. So things keep changing, because obviously we always follow the Western world in most of the things. Again, in US and US, predominantly US, Europe, robotic has taken over, and let it be Japan, Korea, the robotics has taken over. So we just need to, it's almost, we'll be reflecting the same thing. Only thing will be a decade less and things like that, but it just happens.
So this Whipple procedure is mostly considered as a technical part. Like, how is it complex, and how did you get used to it? You are used with this body anatomy and all. But with this technicality, how did you get used to it?
I always say these kind of complex surgeries, you should not take it as one surgery.
Yeah.
You should just divide it into 5 or 6 procedures. So it's like, say for instance, every step you should be like, okay, this step is one procedure. Say there is, if you're going to do a resection, we call it as a resection, where you remove the tumor, where you distal portion of the stomach, you need to remove the gallbladder, you need to remove the bile duct. All that, what I usually do is I divide it into 2 major halves. The first half will be the resection half, where I just resect everything. Then from the day one I've been doing a Whipples procedure, I'll tell the entire team to descrub. So I'll tell the entire team to descrub, a little bit, take a break of 5 minutes or 10 minutes, just have a coffee, just freshen up with a fresh mind, and then again start the reconstruction part. Because when you're doing a resection, the reconstruction is the most important. Say any surgery from the step 1 to last step is most important. Any step you make a mistake, it's going to reflect on the outcomes. So the reconstruction part, that's why I always divide it to initial half of one surgery, second half of one surgery, and then proceed. So these are all small things which we do to help to, say again, not only me, again the team should be fresh. You'll have a new set of hands, new set of mind, and then to go forward and things like that.
Could you describe a case that stood, like, especially the complex cases that had great recovery and a great stood with the patient actually with this robotic surgery?
Say, okay, I'll put maybe a couple of months back, we operated on an 86-year-old gentleman for a pancreatic cancer with this robotic program. In this program we had operated. Next thing is, we have had something very unique. One of the patients had undergone she had donated her kidney to the husband. So again, she had donated her kidney to the husband, and that was a right side kidney to the husband. So pancreas is a little bit on the right side. So again, doing a surgery for her was also a little challenge. It's very unique. So no one gets that. It's like exposure to do that most of the time. It's once in a lifetime. I don't even think we'll get it again. Nothing is, I have operated on a patient where it's called malrotation. Say usually what happens, all the small intestines are on the predominantly on the right side, and predominantly on the left side, and large intestine which on the right side. See here what happens, it's a reverse. Say most of the small intestines were on the right side and then going. So it's called malrotation. That's one unique. So elderly patient, post-transplant patient, post-malrotation patient, all this we have seen.
So do you and the Apollo Cancer Center have a future plan on setting up a training hub who want to specialize in Whipple procedure with this robotic pancreatic surgery?
Yeah, definitely. See, we are working on, already we have got students who get trained by us, who are doing surgical oncology, who get trained by us. We are also wanting to have a fellowship program, especially for robotic. It's on the pipeline. And definitely we have got this, not only for Whipples, for all the other robotic procedures also, we have got a fellowship program. And this all, a day one a hospital starts a robot cannot have a fellowship. you need to keep consistently doing. Your entire team should master it. Only then you can exchange the knowledge to other juniors and things like that. This we have got. We believe in the concept of giving a good treatment and also teaching the junior colleagues, and that's why our center is extremely good in surgical oncology, and people from all over India will want to come and work with us and study with us. We are blessed to have this organization.
Like, what message would you give to the aspiring young oncology surgical professionals?
Say, first thing is be passionate about your work. Say, only if you're going to be passionate, see, if you take it as a burden, you can never do it. If you're looking at the money aspect, don't even think that is a profession. If you're very, very passionate about it, and if you're ready to sacrifice many things, it should be only your work and your family, nothing else. If you're ready to sacrifice everything, I think that's the way to go forward, because you cannot be half here, you cannot be a half businessman, half doctor. You cannot say I will not come on a Sunday, I'll not spend. You can never be work from 9 to 5 and give good outcomes. You need to dedicate your life to the entire specialty. That can come only with passion, and definitely if you have a good passion, the outcomes will be better, and that can be seen. That's why I'll say you need to be passionate, and you should never be time bound, and you should be dedicated. That's all.
Thank you. Like, how does this program contribute to this Apollo larger mission to getting global standard to this Indian patients, actually?
But, definitely. See, again, that's why I said Apollo as such, see, we have got all the treatments. Like, when it comes to oncology, whatever treatment in the best of the centers or more, we have got it in our organization or the hospital, especially in Chennai. We have got everything. And thanks to the management who has made it extremely being supportive, because generally any organization without the top support, it cannot be done. It's not an individual thing. It's a system which you need to have a lot of support from the management side, which has been very open. They want to get the best out of everything. So that's what we keep doing. And I think we get a lot of international patients coming for this kind of complex procedures and things like that. And we are very, very happy to treat patients and give good outcomes.
Thank you for your insights, doctor, and the follow-up, the procedures, the complexities, and it was very well interviewed.
Sure. Thank you so much. Thanks for your time.